Thank you. Thank you again. So, as you requested, first thing is, in order to talk about indeterminate colitis, we really have to understand what that really means. And the true definition of indeterminate colitis should really be made only on full colectomy specimens. So that's the first thing. Just colonoscopic biopsies, even though one may not be able to determine whether it's ulcerative colitis or Crohn's disease, you can't use the term, or you shouldn't use the term, true indeterminate colitis unless it's on a full colectomy specimen. When a diagnosis of indeterminate colitis is obtained on a colectomy specimen, more commonly than not, the actual colectomy was done for fulminant colitis. Now, whether that makes it a harder job for the pathologist to determine whether it's ulcerative colitis or Crohn's disease, or whether it's an actual separate entity that presents clinically with fulminant colitis, is not clear. And what should be used if this is not on a colectomy specimen and you get biopsies that are equivocal, it should really be read out as by your pathologist as chronic inflammatory bowel disease, either unclassified, equivocal or nonspecific, or IBDU, which is unclassified IBD. There are specific features. There's a lot of features on this slide, and I don't want to spend the whole talk talking about the features, but there are macroscopic features that one can see when they're doing surgery for patients with colitis, especially when you open the colon and look at the colon. And I would urge everyone who does, IBD surgery to look at your specimen intraoperatively, because sometimes it will change what potentially you're going to do. And just a technical thing, when I do a pouch, is even if I think that the patient has ulcerative colitis, I'll do the subtotal colectomy, come across the rectum, take that out, look at the colon, and if there's no concern on my part, then I'll go ahead and do the proctectomy at that point, rather than doing the proctocolectomy and then going, oh, I shouldn't have done that. And then there's all these microscopic features, which is what the pathologists look at when they're reading the colectomy specimen, and then come up with, is this indeterminate colitis, is this Crohn's disease, or is this ulcerative colitis? From the pathologist's perspective, the natural history of indeterminate colitis in their literature is that about 2/3 of cases will be reclassified as ulcerative colitis or UC down the line. So they'll be able to tell you, based on the preoperative diagnosis, eventually that it's either Crohn's or UC. But the vast majority of the patients will behave as if they have ulcerative colitis, assuming that there were no preoperative features to suggest Crohn's disease. And occasionally, though, some of the patients will be reclassified as Crohn's, and that's the concern that I think we have as surgeons. Are we subjecting patients with possible indeterminate colitis who really have Crohn's to J-pouch surgery? We all think that that's a bad thing. It's certainly a worse prognosis than with UC, but it may not be as bad as we think. So what I want to do with the rest of the talk is look at the short and long-term outcomes of patients with ulcerative colitis, and this should be, it should be, indeterminate colitis, and compare those outcomes both short-term and long-term. So there's a lot of literature out there. Shortly after the description of indeterminate colitis, the group at the Mayo Clinic at that point, so they started doing J-pouch surgery in 1981. Over a 5-year period, they did 514 J-pouches for what they thought was IBD. But 25 of those patients were judged to have indeterminate colitis. And you can see the reasons why. Strange distributions to the inflammation, deep ulcerations, transmural inflammation, some external findings of creeping fat, and occasionally they used intraoperative frozen section, which I don't think I've ever done, but they did at that time, and they came up with indeterminate colitis. They had a mean follow-up of 38 months status post the pouch, 35 months status post the ileostomy, so they waited about 3 months to close the ileostomy, and they compared the MUC group to the indeterminate colitis group with respect to complications. The groups were pretty similar as far as age, sex, and follow-up time. Any reoperation for any reason was similar between the two groups. Sepsis reoperation similar between the two groups. Pouchitis was higher in the ulcerative colitis group on follow-up, but it didn't reach statistical significance. And the risk of pouch excision, even though slightly higher in the indeterminate colitis group, again did not reach statistical significance. And all of the other functional outcomes were similar between the two groups. So this was the first of the papers that came out saying that it was okay to do pouch surgery in patients who had indeterminate colitis. Several years later, out of the University of Utah, Merrill Dayton reported on 723 patients who underwent a pouch for inflammatory bowel disease. Of that group, 79 of the patients were found to have indeterminate colitis. And they compared them to 565 patients who had ulcerative colitis. Interesting also is it's not that easy to necessarily make the diagnosis, and different pathologists, unless they're very experienced, may come up with different evaluations. And their pathologists at this particular time, when they went back and looked at the preoperative diagnoses, they only agreed about a third of the time that the patients actually had indeterminate colitis. They had a relatively long follow-up of about 6 to 7 years. And again, if you look at the comparison between indeterminate colitis and ulcerative colitis, whether it was for cuff abscess, J-pouch leaks, intra-abdominal abscesses, stricture, pouch fistula, small bowel obstructions, etc., none of those things reached statistical significance. So they were similar in this next group of patients between the indeterminate colitis group and the ulcerative colitis group. And when you looked at pouch function, not as long as a follow-up as long as 9 months, which isn't very long, but basically the pouch function was very similar between the indeterminate colitis group and the ulcerative colitis group as far as stool frequency as well as nighttime incontinence greater than 3 per week episodes in a percent form. So they concluded, again, that most patients diagnosed with indeterminate colitis can undergo a pouch and can expect good outcome. Moving on to Cleveland Clinic, Ohio, 2003 article. We're getting larger and larger series here. So this is 1,900 patients that underwent pouch surgery at the Cleveland Clinic Foundation in Ohio between 1983 and 1999. Of that group, 171 had a postoperative diagnosis of indeterminate colitis versus the remainder, which was 1,399 with a postop diagnosis of mucosal ulcerative colitis. They had these specimens re-reviewed by a single GI pathologist, and then he reclassified those 171 into Group 1, which was indeterminate colitis with features that favored ulcerative colitis, Group 2, what they considered true indeterminate colitis, and Group 3, which was indeterminate colitis favoring Crohn's disease. But of that whole group, there was only 115 of them that they could actually get both sets of biopsies to do that on. So it actually lowered the number that they actually were able to follow up on. But 67% of the patients had, who had indeterminate colitis initially on re-review were felt to favor UC. True indeterminate colitis was only 8 patients, and Group 3 was the IC favoring Crohn's, was also 8 patients. And they compared those to 231 randomly selected and matched patients with ulcerative colitis. And again, if you look at the outcomes here, whether it was pelvic abscess, perianal fistula, major fistulas, leaks, non-functioning pouch or pouch excision, the groups were very, very similar, whether they favored ulcerative colitis, whether they were true indeterminate colitis, or they were indeterminate colitis favoring Crohn's disease, compared to the full group of the full ulcerative colitis patients. And again, they concluded that pouches can be performed with a diagnosis of indeterminate colitis without a significant risk of increased pouch failure or the need to perform pouch excision. This is our data from Cleveland Clinic, Florida from 2004 with 303 patients specifically undergoing double stapled ileopouch anal anastomosis for inflammatory bowel disease over a 12-year period. 56 patients had a pre-op diagnosis of indeterminate colitis. The postoperative diagnosis was changed in the vast majority of patients, like we spoke about earlier, to ulcerative colitis. 1 patient had a post-op diagnosis of Crohn's, and 7 had a post-op diagnosis of indeterminate colitis. The overall complication rate was similar between the MUC group and the IC group, but significantly higher, even though in a small group of patients, with those patients who had Crohn's disease. And at the time that we had published this, no indeterminate colitis patient ended up with pouch failure, and no patient who was finally classified as indeterminate colitis ended up with Crohn's disease. Functional scores, again, were similar between the ulcerative colitis group and the IC group, and a little bit worse in the Crohn's disease group. Again, we felt that it was safe to perform double stapled pouch for indeterminate colitis, and that their outcomes would be similar to those with mucosal ulcerative colitis. Mount Sinai, Toronto, Robin McLeod's group, 1,270 patients. You can see the distribution, 21 patients with indeterminate colitis. Here, there was a slightly higher rate of pouch complications related to indeterminate colitis compared to the UC group, and much higher in the Crohn's disease group. However, when you looked at the overall pouch failure rates, the pouch failure rates were very similar between ulcerative colitis and indeterminate colitis. The pouch excision rates were similar between ulcerative colitis and indeterminate colitis, but there was a much higher, if they had Crohn's, pouch excision rate. And all the other parameters were non-statistically significant between the ulcerative colitis and the IC groups, with significant higher complication rates, specifically pouch-related, when there was an ultimate diagnosis of Crohn's disease. But functionally, the outcomes were very similar. They concluded something a little bit different, that you can do pouches in these patients, and you may need to expect slightly higher perioperative complication rates, but in the long run, the patients will do just as well with indeterminate colitis as they would with ulcerative colitis. A large series, which was a combined series from the UK, looking at 2,500 patients at 10 units over a 30-year period. Again, about 9% of patients, 9 patients, 3.7%, having a preoperative diagnosis of indeterminate colitis. This looked at it a little bit different way, looking at which patients required a salvage operation in the future. And again, when you look at the group, the indeterminate colitis group was a very low group, but that's probably based on the fact that it was a small group. But it wasn't that most of the patients required a salvage operation. And again, when you look at pouch failure, the pouch failure rates overall, if you had a septic complication, was 35%, poor function 30.8%, and Crohn's 5.3%, but none of this could be related back if the diagnosis was related to indeterminate colitis. Lastly, the last bit of data I want to run through with you is a longer-term study from the Mayo Clinic with 1,800 patients over a longer period of time. 76 of those patients had ended up with a post-op diagnosis of indeterminate colitis. Longer term than that, 15% of them were reclassified as Crohn's disease due to changes clinically in the post-operative period, and 2% of mucosal ulcerative colitis patients were actually reclassified. If you look at the long-term complications in percentages between ulcerative colitis, indeterminate colitis, and Crohn's disease, pouchitis was very, very common, both at 10 years and 20 years amongst the three groups. But there was no real statistical significance between abscesses, fistulas, small bowel obstructions, or strictures, other than in the CD group. But the groups here did not show that there was a worse outcome in patients who had indeterminate colitis, and the functional results were also similar, again, with the exception of increased stool frequency in the Crohn's disease group. So I think based on all of those studies, one can say that indeterminate colitis does not necessarily lead to pouch failure, and patients who have indeterminate colitis can probably get a pouch. But what if they did end up going on to have Crohn's disease? Well, this is just a list of series that look specifically at pouches for Crohn's disease. It's a small number of patients because we don't usually do this, at least intentionally. But even in the worst of situations, 48% pouch excision rate or 45% pouch failure rate still means that 1 out of 2 patients, even if they're ultimately diagnosed with Crohn's disease, are going to be ileostomy, won't have ileostomies long term. So that I think, in conclusion, the data support that most indeterminate colitis patients have similar outcomes to those who have ulcerative colitis. Complications in some series may be slightly higher, but the long-term pouch success rates and the retention rate and the functional outcomes were very similar to those patients who have MUC. Even if a patient ultimately has Crohn's disease, they will have at least a 50% chance that they can maintain their pouch long-term and avoid the need for an ileostomy. So I think that the answer is yes. Thank you.